Okay, well, hello everyone again. Thank you for joining us for the Canadian Liver Foundation and the University Health Network Ajmera Transplant Centre webinar series on liver disease and liver transplantation. My name is Nem Maximovich. I am the Senior Manager of Support and Education at the Canadian Liver Foundation, and I will be the moderator and the host for this webinar. I would like to start by acknowledging that the Canadian Liver Foundation's national office in Markham, Ontario, is situated upon traditional territories of the Anishinaabes peoples and of the Haudenosaunee peoples covered by the Upper Canada Treaties. The Ajmera Transplant Centre and the Centre for Living Organ Donation at the UHN, our partners for this webinar, are also located in the Toronto area, traditional territory of the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee of the Wendat peoples, and now home to many diverse First Nation, Inuit, and Métis people. This is the first session of a quarterly series. In this first segment, we will discuss advanced liver disease, clinical management, and some treatment options for liver failure. At the end of this presentation, we'll provide some additional information on the upcoming sessions that will be part of this series. We are joined tonight by two presenters, Dr. Cynthia Tsien from the Ajmera Transplant Centre at the University Health Network in Toronto, Ontario, and UHN partner, patient partner and advocate and liver recipient, Andrew Strickland. As for our agenda, we will have our two speakers complete their talks first, prior to moving on to a question and answer portion. So feel free to use the comment feed or the Facebook comment feed to ask your questions during the presentation. And we'll also have some already asked questions ahead of the presentation. So we will be answering all these questions following both speakers' presentations. And of course, this webinar will be available post-event on the Canadian Liver Foundation and the UHN website, as well as the Canadian Liver Foundation and Centre for Living Organ Donation Facebook and YouTube pages in the coming days. Now, for those of you who may not be familiar with the Canadian Liver Foundation or the UHN, I'll provide you a brief overview of who we are and what we do. So to start, we at the CLF, we were established in 1969, and we're the first organization in the world created to help people with liver disease. We are committed to promoting liver health and improving the prevention, diagnosis, and treatment of liver disease through our four core pillars. That's research, education, patient support, and advocacy. Our partners at the Centre for Living Organ Donation were established by UHN Transplant, now called the Ajmera Transplant Centre, in 2008. Its mission is to improve access to living liver and living kidney donations and transplantation. The Ajmera Transplant Centre is Canada's largest transplant centre, and UHN's Toronto General Hospital is ranked among the top 5 hospitals in the world by Newsweek. At this time, I'd like to welcome our first speaker, Dr. Cynthia Tsien. Dr. Tsien, for those of you who may not be familiar with her, completed a residency in internal medicine and gastroenterology at McGill University in Montreal. She underwent extensive training in hepatology during her fellowship at the Centre for Liver Disease in Cleveland Clinic. After her fellowship, she worked as a clinical associate in the University Health Network until she was recruited as the assistant professor of medicine at the University of Ottawa. Cynthia obtained a master's in public health at the John Hopkins University and developed significant interest in teaching and postgraduate education. Dr. Tsien is currently a transplant hepatologist, liver specialist, and director of education at the Ajmera Transplant Centre. Now I'll hand it over to our first speaker, Dr. Cynthia Tsien.
Thanks so much for that introduction. I'll just share my slides. And there we go. So as was mentioned, this is the first in a series of sessions. And I wanted to start off just with a small disclaimer that We do not provide personal medical advice. So if you have some questions as to how today's information applies in your particular session, I would recommend that you speak to your doctor. And I also wanted to tout one of my colleagues, she's in Alberta. She has a fantastic website, cirrhosiscare.ca, which has a lot of helpful information for patients pre-transplant with cirrhosis. And hopefully over time, we'll be able to develop our own website for post-transplant information. And again, there's definitely going to be a lot of questions around transplant. We did plan it as sort of several sessions to go over the pre and the post-transplant journey. So today, I'm mainly going to be talking about, when should you start being referred for transplant? And then our third session will go more into specific indications and the evaluation and that sort of process. So I wanted to talk sort of like a liver 101 and introduce you to the amazing organ that is the liver. Talk about some of the normal functions of the liver, and then what happens when things go wrong. So what is cirrhosis, and when should you start thinking about a liver transplant? The other caveat is this is not an exhaustive list. I tried to make it exhaustive, so I hope it's not too confusing, but there are some special considerations because of time constraints. I might just focus more on the liver cancer and alcohol, but there's many, many reasons to have a transplant, and I'll briefly touch on some of them, and it won't be an exhaustive list. So just to start off with, your liver sits on the right side of your body, just under the diaphragm above the stomach. And it roughly is the size of a football and weighs around 3 pounds. And the liver is an amazing organ with this very unique dual blood supply. And so you can see here that, most organs, you have the artery giving you oxygen and the veins take away, like the blood that is deoxygenated. But the liver is super unique in that it has 2 sources of blood supply that give it oxygen with the artery and nutrients in the portal vein. And so the blood that comes from your intestine goes up into the liver, and you'll see that the liver does a lot with those nutrients. It consists of 2 lobes, which is why you can give away part of your liver, and 8 segments. And each of these segments has its own blood supply and supply with the bile duct. So that's why you're able to, segment the liver. And each segment consists of small lobules, so 1,000 lobules in all. And these lobules are connected to bile ducts, and they all form like an interconnected tree so each lobule has its own like artery, vein, and bile duct. The liver acts as a filter, a factory, and it also detoxifies. It does a lot for your body. It does a lot for you. It's an altruistic organ, and I'm going to briefly go into each of these functions, because when the liver stops working, this kind of explains like what your symptoms are and why they can be very diverse and like very different. So the liver, as we saw, gets all that blood flow from the intestine. So you have all these nutrients that go into your blood, and then they go up to your liver. And so it processes these nutrients absorbed from the digestive tract, removes bacteria, and produces immune factors. And so the liver uses all of that, protein and carbs and lipids, and it breaks it down. So metabolism, it metabolizes all the protein, carbohydrates, lipids. It puts them in various storage modes so that you can access these nutrients later for energy. And it uses that energy to produce things for the rest of the body. So it produces proteins, albumin, clotting factor. So this is important, when you cut yourself and your blood needs to clot, the liver is producing all these proteins, including clotting factors. And it also produces bile, which is important in its next role as something that detoxifies. So the liver is basically a way of removing a lot of waste products. So toxins such as alcohol, the drugs that you ingest, so like, medications, and also, when you break down all the protein and the carbs, there is waste products generated from that, and that's all excreted in the bile. So the liver produces 500 to 600 milliliters of bile per day. And that bile consists of bilirubin, water, electrolytes, bile acids, and these are all sort of like detergents that help your body get rid of all of these toxins. So it's a way of getting rid of all these byproducts. So usually you either pee out toxins or you poop them out. And so the bile acid, the bile is excreted into your gut. And then, it actually gives the color to your poop. And so that's how you are getting rid of all these toxic compounds. So you don't need to answer, you can kind of answer in your mind, but I thought that we would have a small quiz on what causes liver damage, because I know a lot of people, when they first get diagnosed with liver disease, they say, hey, I don't drink alcohol. Why am I having issues with my liver? So you can think in your head, what causes liver damage? So A, alcohol, B, hepatitis B, C, primary biliary cholangitis, or D, Wilson's disease, or E, all of the above. And so we're going to say all of the above. So there are many, many causes of liver disease. And this is just sort of like a superficial, unfortunately, I don't have the time to sort of go through every single condition, but there are many, many things. It's not just alcohol that causes liver damage. And they can be hereditary causes, so things that are passed down from your parents to your children, autoimmune conditions where the body attacks itself. And so autoimmune conditions also include conditions that attack the bile duct, so primary biliary cholangitis, primary sclerosing cholangitis. Infections, so very common ones are the viral infections, hepatitis B, C, and D. The most common causes are really alcohol, fat in the liver. So unfortunately, we as a society are getting heavier, and all that fat that we're carrying around deposits in the liver, and viral causes. So those are really the top causes of requiring a liver transplant. Fatty liver, alcohol, and viral, but all of these things can really cause liver damage. So I wanted to go on to, what is cirrhosis? And on the left here, we have a nice healthy liver. And on the right, we have, unfortunately, a liver that's all hard and nodular and cirrhotic. So, this is kind of the time frame of what happens when you develop cirrhosis. So you have a normal liver, and then, over 20 or 25 years, you have this like chronic hepatitis. So all of these things, even though they're all different, they all cause damage to the liver in the same way. They cause this like inflammation. And then over many, many, many years, you develop cirrhosis. And so first you have so when we talk about fibrosis, we stage it as 0 to 4, 4 being cirrhosis. And so here you see that, when you have this persistent inflammation, so like this hepatitis from whatever cause, it results in collagen deposition. And collagen is basically scar tissue, okay? So when you cut yourself, that scar develops from collagen deposition. This extra collagen leads to stiffening of the liver and what we call fibrosis. And it can be like 1, 2, 3, or 4. Unfortunately, this scar tissue kills the healthy liver cells, causing more scar tissue to form. And it can also affect the blood flow through the liver and cause what we call portal hypertension. So like high blood pressure in the liver, which causes a lot of these other side effects that we're going to talk about later. But I think what is key to highlight is that, this is a very slow process that takes decades. But unfortunately, because the liver is so amazing, it's so resilient, a lot of the times in those mild to moderate stages, you don't get any symptoms. So what you might see is, your doctor does a routine checkup, and then you have some abnormal liver enzymes, and that might be the first clue that you're starting to have some damage to your liver. But you could be perfectly asymptomatic and have no symptoms at all. So as we said, 4 is really severe damage and cirrhosis. And we usually, would like to identify people who are at a stage 2, because you're kind of halfway to developing cirrhosis. And so these are the type of people that we really try to target and say, hey, why are you having liver damage, and can we reverse that? So how do you diagnose this damage? Some of you may have had a liver biopsy. Some of you may have had a fibroscan. So essentially, to determine where you are on that scoring system, there's a couple of different methods. The most common is a fibroscan or a biopsy. And the biopsy is really considered the gold standard, because you actually have a needle, go in, you take a piece of tissue, and then the pathologist can look under a slide and say, okay, this looks like F2 fibrosis or F3 fibrosis. And then a fibroscan is a non-invasive way of determining how much tissue damage there is. And basically, you have a special type of ultrasound machine with a probe that goes up against the liver, and it taps on the liver. And depending on certain metrics, there's a wave that goes through the liver. And depending on how fast or how slow that wave travels, we can tell if it's like a healthy liver or a fatty liver or like a scarred and damaged liver. So the good thing about a fibroscan is that it doesn't require any needles, but it's not quite as accurate as a liver biopsy, which is considered the gold standard, but there is a risk of complications. And so most people, when we want to know how much damage there is to the liver, we'll do either a fibroscan or a liver biopsy, and then we can tell like how much damage there is. But many people walk around for decades not knowing that they're developing this inflammation and damage until they start developing symptoms, which can be quite advanced, because the liver, again, just can keep rolling and functioning along even with all of this damage to the liver. So we're going to talk about next compensated cirrhosis. So in the initial early stages, you can see that first you have cirrhosis, and then you have end-stage liver disease and death. So this is more like decompensated cirrhosis that we're going to talk about. But initially, you've developed cirrhosis, and you may or may not feel sick. So even when you're cirrhotic, you may not have any symptoms. You may feel tired, have a poor appetite, lose weight, nausea, or you may feel perfectly fine and have no symptoms at all. The key thing is that there is still a risk of primary liver cancer. So all that scarring and damage is a good milieu for like abnormal cells. So it is very important to do screening ultrasounds every 6 months. Even if you have compensated cirrhosis and you don't have any symptoms at all, very important to do your ultrasounds every 6 months so you can pick up any cancer early. And then really, when you're at the cirrhosis stage, really, there isn't really any medication that will reverse the fibrosis. Really, what you want to do is catch liver disease early so you can treat the underlying cause and prevent cirrhosis. Once you actually have cirrhosis, I mean, this is a generalization. There's always exceptions to the rule, but in general, if you have cirrhosis, you cannot go back to say like an F2 fibrosis. I mean, it's a bit controversial because, you know, people say, oh, you know, is an F3 like an F4 early cirrhosis? Maybe, you know, if you were really early, maybe you caught it in time and reversed it. But in general, if someone has labeled, if the doctor has labeled your condition as cirrhosis, it's very difficult to go back to like even like early like F3. So you know, fortunately, if you treat the underlying cause, hopefully you will not progress, but you would still need to do those ultrasounds every 6 months. So again, the key is really to make sure that you treat the underlying cause so the disease doesn't get worse, and then you start getting symptoms of decompensated cirrhosis. And that's when you start talking about indications for liver transplantation, okay? So our referral criteria are mainly chronic liver disease. So you've developed symptoms, therapeutic options have been exhausted. And so that's usually when people are referred for a transplant. And we'll talk more in the later talks about sort of like the evaluation, you know, indication and contraindications to transplant, because there are contraindications to transplant. And then also, you know, the other big indication for transplant would be liver cancer. And I'll briefly touch upon things like acute liver failure, metabolic disorders, and I'll touch briefly on criteria for alcohol, because that has changed. And so that I will talk about now and not like in the eval session. But essentially, so when you have chronic liver disease, cirrhosis, and you start developing symptoms from that liver disease, okay, it's called decompensated cirrhosis. And usually there's two things that happen. First is that your liver cells are not functioning. So remember, they're getting replaced by these abnormal cells that don't function properly. And the other signs and symptoms you get are from the portal hypertension. So I'll speak about the lack of functioning liver cells first. And so if you remember, you know, the liver does so much that when the liver stops working, you can kind of understand why you're getting the symptoms you're getting. So for example, you know, the liver produces all this protein for your body. And so, you know, when the liver stops functioning, you can't use that protein, you start losing weight. So you can often see like patients with decompensated cirrhosis, they look unhealthy, like really skinny. You can have low blood sugar because the liver, you know, acts to regulate your blood sugar, producing sugar and storing sugar. And bleeding, right? Because of those coagulation factors we talked about, clotting factors. So you may have a predisposition to more bleeding. And then the liver also, we talked about, it removes toxins from your body, right? So if the liver can't remove those toxins anymore, that's when you start getting something called encephalopathy, where the toxins are building up and can affect your brain. And also jaundice, where you start turning yellow. So this is all indicative that your liver is not functioning. And we tend to use something called the sodium MELD score to really quantify like what that means in terms of your prognosis. So there's something called a MELD score calculator, and it gives you a number between 6 and 40, and it's based on basically things like bilirubin, INR, which are directly affected by your liver, and then also the sodium level in your body and creatinine, because we know that when the liver starts getting sick, it can also affect the kidneys. So if you have a score so 6 is the best, 40 is the worst. And so if you have a score of 11, your 3-month mortality is 6%. So what that means is that in 3 months, your likelihood of dying from liver disease is very, very low, like 6%, minimal. But if you have a really high score of 33, your 3-month mortality could be as high as 50%. So like your risk of dying in the next 3 months is up to 50%. So obviously, the higher your score is, the sicker you are, the more you need a liver transplant. And so usually we will consider putting people on a list when your MELD score is anywhere from 11 to 15. So usually like around 15, we start saying, hey, you know, your mortality is not that high now, but if your liver disease continues to progress, then, you could die from your liver disease, and we need to start working you up now, because it does, you'll see in the next session, it does take some time to put people on a transplant list. So one way of sort of monitoring your liver, seeing how you're doing, is with the MELD score. And that is very helpful. If your doctor can tell you what your MELD score is, it kind of is a way of reassuring you, like, oh, my number is 8, I'm doing fine, I don't need a liver transplant right now. And then we're going to talk about portal hypertension. So that's, remember I said that when you get that hard, scarred, cirrhotic liver, it affects the blood flow. And so that can cause portal hypertension, which is high blood pressure in your liver. And that causes all of these complications. So ascites, varices, encephalopathy, and very rare hepatopulmonary syndrome. And I'm going to go into more detail in the next couple of slides. So basically, I'm sorry, this is a bit complicated, but basically, if you ignore sort of the writing, as you can remember, we said that, there's blood flow going into the liver, and then it goes out to the rest of your body, right? To, send out all those great nutrients, to the rest of the body. And so what happens when the liver is cirrhotic is you're getting resistance. So basically that hard, scarred liver, the blood just, it's like a river. It just can't flow through. And so what happens when that river meets that dam? It backs up. Okay, there's some other things that happen too, but basically that blood is backing up. And so you start getting pooling of blood in other places, such as near the esophagus, like that's the tube that goes from your mouth to your stomach. And that can cause the varices. And that blood not being in the right place, pooling in other areas, also affects your kidneys. And so that's why you get things like ascites. So basically those changes in the blood supply and where the blood is affects the kidneys, and then the kidneys start retaining water and salt. And so that's what ascites is. It's fluid in your abdominal cavity. So, extra fluid where it shouldn't be. And that can cause problems with your kidneys. So what we call hepatorenal syndrome, where you have kidney failure due to your liver, and spontaneous bacterial peritonitis, where you get spontaneous infections of the acidic fluid. The varices we talked about. So as we mentioned, the esophagus goes down to the stomach. That pooling of blood backs up around the esophagus. And then you get these big veins in the esophagus that can pop and they can bleed. And so you would need an endoscopy, a camera that goes down into your stomach to try to fix these veins and stop them from bleeding, which are usually rubber bands that we put around the varix. And you can see here a rubber band around a varix that stop bleeding. And then, as we mentioned, your liver is responsible for taking toxins out of the blood. And what happens is with the changes in the blood flow, instead of going to the liver and the liver takes out the toxins, you get shunting away from the liver, and there's less liver cells to take out the toxins. So you get this buildup of toxins, and they travel through your body until they reach your brain. And then it causes this temporary worsening of your brain function. So irritability, personality changes, what we call day-night reversal, where you're up all night and you're sleeping during the day, confusion, not knowing where you are, not knowing who you are, and it can actually progress into even a coma where you can't wake up. And hepatopulmonary syndrome is a similar thing. It's very, very rare, but basically you have this shunting, basically. So, these are your lungs, this is the blood goes to your lungs, and then you get oxygen, and now you have this nice oxygenated red blood. But because of shunting and dilatation, the blood is not getting to the lungs to get all that great oxygen. And so you get low oxygenation, you might need oxygen. And so, if you look at the survival of decompensated versus compensated cirrhosis, you can see transplantation is really based on numbers and your probability of survival. So because the issue is that transplant is not without its own complications. There is a risk of death. There is a risk of losing the new liver. There's complications from the medications. And so if you look at compensated cirrhosis, the 1-year survival is 99% and the 5-year survival is 85%, which is comparable to a transplant. So that's why even when you're cirrhotic, we won't jump to doing a transplant, because if I tell you, you can keep your own liver and your 1-year survival is 99%, or I could do a transplant and your 1-year survival is 95%, it makes you wonder, like, why do you need a major operation, staying in the hospital, right? But if you look at decompensated cirrhosis, as soon as you start developing ascites, bleeding varices, encephalopathy, then the survival gets reduced. And that's when you start thinking about a transplant, okay? And so the question is always, well, when is this going to happen for me? And we say that usually there's about a 5 to 10% risk per year of going from compensated to decompensated if you don't control your underlying disease. So for example, if you were drinking alcohol and you had compensated cirrhosis and you stopped drinking completely, then your risk is going to be much less of developing these complications. If you have hepatitis C and you were treated and you have compensated cirrhosis, then we know that your risk of developing this decompensation is much, much less unless you have another coexisting liver disease. So that's the problem with so many liver diseases. You could have hepatitis C and alcohol. So if you're still drinking, even though your hepatitis C is cured, there's a risk, right? And so usually there's, about over 10 years, there's maybe about a 1 in 3 chance of developing encephalopathy, 1 in 4 chance of developing bleeding, and about a 50-50 chance of developing ascites if your underlying disease is not controlled. But that's why we also don't do a transplant preventatively, because if you have a 90% chance of not developing these complications in the next year, then we'd rather not give you the risk of undergoing a surgery that has, a 5 to 10% risk of death. So I'm gonna I don't want to take up all of the time and I want to let Andrew speak. So I'm just gonna briefly talk about special considerations. There is something called acute liver failure, which is very rare, 1 case per million, where people develop severe liver injury without any pre-existing liver disease. And that's a different indication for a transplant. But you wouldn't be here listening. I mainly mentioned it if you had a transplant and then we're like, hey, my condition is not listed there. But usually people who have acute liver failure are very, very sick and need a transplant right away or they don't survive. So this is not like a 3-month, 6-month, 5-year process. They need a transplant right away. And the most common is actually paracetamol, which is basically acetaminophen, so Tylenol. So Tylenol overdose is the #1 cause of acute liver failure. And then I also wanted to talk about liver cancer. So that is a very common cause of transplants. About 1/3 of our wait list consists of people who are listed for liver cancer. And then just to tell you, so the liver can have many, many lesions, okay? Especially like a lumpy, bumpy liver that's cirrhotic can have many different lesions. And so this is why we usually do an ultrasound screening every 6 months, but the ultrasound is really just to tell us, is there something concerning or not? So if you see a spot on the liver, it could be a solid liver lesion, it could be a cyst, it could be malignant, which means like cancer, or it could be benign. And some cancers are also benign. Like benign basically just means that it's not going to be the type of cancer that, takes over your body and like, goes everywhere. Because of that, we usually have to better characterize these liver lesions with other tests. So these are things like a CAT scan, an MRI, Some places have special ultrasounds called contrast ultrasounds. And so sometimes, you know, when I tell my patients, oh, we found something on the ultrasound, they get worried, but really the ultrasound is just for screening. And then you need a CT or an MRI to see if this is really cancer or not, because there could be a lot of different things that cause liver lesions, and some of them are nothing to worry about, like hemangiomas, you know, adenomas, regenerative nodules, and some of them are cancer. And so I'm not going to really go into the cholangiocarcinoma, which is a cancer of the bile ducts, and colon cancer, because I feel like that could be a talk on its own. But I'm going to talk mainly about hepatocellular carcinoma, which is a primary liver cancer, because what happens is sometimes you can have cancer in other places and they travel to the liver. So like, for example, colon cancer, breast cancer, you can get liver spots on the liver, but it's not a primary liver cancer. There is a study that we are doing transplants for people with colon cancer, but I don't want to confuse the issue too much. So I'm going to mainly focus on primary liver cancer, which is hepatocellular carcinoma. And so, you know, this graphic is quite complicated, but the bottom line is there's a lot of potential treatments for a primary liver cancer. And the nice thing about transplant is it's potentially curative, and it cures the underlying liver disease. So if you have cirrhosis, you're taking out the cancer and you're changing out the liver to a new liver that doesn't have cirrhosis, and it can treat multiple spots. So instead of getting like a local treatment here and here and here, you can treat all of the cancers at once. And basically, there's different indications. I'm not going to go into all the indications for liver transplantation, and people have done basically like different criteria and looked at the 5-year survival. So basically, like, you can do transplants for like a single lesion that's less than 5 centimeters, and you have really great outcomes, 5-year survival of 75 to 80%. So at the end of 5 years, 80% of people are still alive. And then if you try to push the envelope and do bigger tumors and more of them, then the survival starts going down to like 35%, 50% 5-year survival. And so that's why it's hard to list sort of all of these criteria, but there are specific criteria, and your doctor can tell you when a transplant might be, you know, the best treatment for you as opposed to other treatments. I'm going to skip over metabolic disorders because I don't have time, and I'm going to finish off just talking briefly about alcohol, because I think a lot of people are not aware that there is no 6-month rule anymore. So instead, this is not the exhaustive criteria, but these are some of the criteria, and it comes down to, we want to see that a patient is willing to commit to abstinence, so like no more alcohol, and they're willing to commit to treatment. So alcohol use disorder is actually like a very well-defined disorder. So like there are actual criteria to diagnose someone with an alcohol use disorder. And so this is why, you know, now when we assess someone, it's not just a hepatologist assessing someone with alcohol-related liver disease. There's actually a psychiatrist who's involved as well, because they're going to say, hey, this person does or does not have an alcohol use disorder, and they do or do not need specific treatment for alcohol use disorder, which is usually stuff like counseling and, you know, cognitive behavioral therapy. So basically, you know, if your last drink was 6 months plus 1 day ago, or your last drink was 3 months ago, it doesn't matter anymore. It's really about being willing to commit to abstinence and being willing to commit to treatment if a psychiatrist has told you that you need to do it. And so now it's not, you know, we now collaborate, not just the liver transplant doctors and surgeons, but, you know, psychiatrists, social workers, and we're lucky enough to have, you know, specific social workers who help people link in with psychosocial treatment for their alcohol use disorder. So just in conclusion, liver damage can take decades to develop. So it's really important to see your doctor, get like regular physicals, and treat any underlying conditions to prevent cirrhosis. So if you're told you have a fatty liver, or if you have hepatitis B, like it's important to try to understand like how much damage has there been already, and can you do treatment to prevent cirrhosis? Because that's really the best treatment, is to prevent cirrhosis. And then unfortunately, if you've already had cirrhosis and it's progressing, liver transplantation is a life-saving treatment. But it's really indicated in specific situations to really improve outcomes. So we don't usually do sort of transplants like prophylactically, like in case you develop decompensation in the future, but it's more like if you have decompensated cirrhosis, like all those complications I was talking about that do not respond to medical management, if your MELD score is high, if you have liver cancer, so like things that will impact your survival, is generally when we would proceed with a transplant evaluation. And that's it for my slides. I'm not sure if we're going to take questions now or afterwards.
All right, thank you for that, Cynthia. So we'll move into our second speaker for today, and then we'll take the questions right afterwards once Andrew shares his story. So again, thank you, Cynthia, for that great talk. Our next speaker, Andrew Strickland, he is a patient partner of the University Health Network, and Andrew comes today from Hamilton, Ontario, where he lives with his two daughters, and he is actually a recent liver transplant recipient and is here today with us to kindly share his journey with liver disease from early diagnosis and everything that he's been through in the early stages. So what I'll do, I'll hand it over to Andrew, and we'll have a few slides following this introduction of pictures that he's been through, which will be helpful for our audience to see kind of some of the aspects that he's been through throughout this journey. So I will hand it over to Andrew.
Thank you. It is truly an honor to be here tonight, and thank you for the opportunity. I'm here to speak about my journey with my referral path and ultimately what happened and my outcome with end-stage liver disease. It all started, I guess, with my GP back in 2016. I was referred because some of my blood work was, I had some irregularities, was referred to a GI doctor instead of a hepatologist. I was diagnosed with a fatty liver, and that was 2017. I had blood work, more tests, ultrasounds, and again, through this process, the GI, I was many cancellations. It was very tough to navigate through the healthcare system, and I'm in Hamilton, where we have some great hospitals. In April 2018, I was away, and again, I was living my life just like I normally would, except I did cut back on my alcohol content. I was in Florida, I came back, I couldn't walk, and I went right to the hospital, and I had a hernia. And that's pretty much how they found out about my liver functions and my liver problems. They wanted to do hernia surgery right away. But because my blood work showed that I had low platelets and hemoglobin, I was not eligible because I would bleed to death during the surgery. So I was referred back to my GI doctor, and again, more cancellations. It was tough to see different doctors and get blood work and get tests. So in 2019, I wasn't getting anywhere. So beginning of 2019, I went to a private care facility in Toronto, and I went through a battery of tests. And it was funny because my GI doctor said that I was having some liver issues, and at that point in 2019, I think it was March, he had said that I was living with 20% of my liver function. And when I went to Medkin, which is in Toronto, and I was told that there was nothing wrong with my liver, it was fatty, no signs of cirrhosis. And then I went to another doctor that had mentioned that it was onsets of cirrhosis. Through that, it was very, very, very confusing. I went back to Toronto for a follow-up. I was very bloated. retaining a lot of fluid. And he said, go back to Hamilton and get a paracentesis, which again, that was draining the fluid out of my abdomen. Went to the hospital. They told me to go back to my clinic. There's the first picture is me with, again, a lot of ascites. That was October. So, from September 17th, emergency didn't do anything for me. Very uncomfortable. Went back to the hospital the next day. Got my first paracentesis. The picture of the bags of fluid, that was what came out of my stomach every Friday, between 8 and 11 liters of fluid. Kind of got used to it, going every Friday at 8 o'clock in the morning, and that was my weekend. But there was complications after that because they're draining so much of your nutrition out of your body. I would have leg spasms, like there was leg spasms. I'd have to wrap my legs in ice. Couldn't lay down. And again, at this time, I still hadn't been diagnosed with cirrhosis. I was having some major liver problems. Sorry, I'm just trying to refer to my notes. I apologize. So in August, I believe, again, a lot of the complications started. But again, I was having some symptoms of, weight loss, very tired, sleeping a lot, sick on a regular basis. So again, going through my process with, the clinic in Toronto, coming back to Hamilton, I guess September 17th was my first, September 18th of 2020 was my first paracentesis. And that went on for, I guess, up until October 31st, which is a picture of me and my grandson with the bloated stomach. I had an episode of hepatic encephalopathy in the middle of the night. Didn't know who I was, where I was, what was going on. The ambulance came and got me. They took me to the hospital. And again, those dates are pretty sketchy, but the 1st of November, I went in for, I believe, 2 days, came back out 2 days later, went back in by ambulance. Again, bad episode of hepatic encephalopathy, confusion, disoriented. And I was there for about 2 days, and I believe it was on the, let me see, just want to refer to this. So I think the 5th was the second time I went in, and on the evening of November 6th, I became non-responsive to stimuli. So I would not wake up. They would do tests. I could not come out of it. And they submitted me to ICU. Bear with me, please. I was sent down to ICU and hooked up and put on life support for about 5 days. When I came out of my, I guess, off life support and respirator, I was told that I had end-stage liver failure. So there was really, a lot of people around me knew I was sick, didn't know what it was. I'd cut back significantly on drinking. My last drink was September long weekend, 2020. I had a glass of wine, and that put me into a 3-day sleep. And so between September and Halloween, I was, just not with it quite a few times. Went into ICU. I came out with a family meeting. My family was around my bed, and my doctor in ICU had mentioned that I needed to be put on the transplant list. And my spleen, my bowel, my liver wasn't working. And so I was there for until I believe the 26th of November. I had to learn how to walk again. There I am with my walker. Lost all my muscle mass, lost tons of weight. I was down from 250 to 225. Now that picture was, I believe, 180 pounds. This all happened very quick to me. I knew I was sick, but not to the level of end-stage liver failure. Within 2.5 months, I was in ICU, again, full-blown liver disease, and I would start the process. At the end of November, I got out. I was released to a home, went back in 2 more times, and then I was there over Christmas till December 30th. Again, it's very tough to navigate through the system, and I hear what the doctors mentioned tonight. And again, it's a lot to take in. It's a lot to navigate through. Because of my confusion, I was not retaining information. The doctors come in, speak very quickly, and again, with COVID, only my sister and my girlfriend could come in, which kept very good notes. My sister is a nurse practitioner, and again, soon to be my liver donor. So, I guess what I stress here, and I don't want to take up too much time, but, you need to be your best advocate. You need to take charge of your own health and your care. And, if you're not with it, like I wasn't, to have somebody there on your, to listen, to make notes, to watch your medication. When I was good, I'd been in the hospital back and forth up to April, probably 5-6 more times. And they're very busy. The hospital, the care, it's amazing. We have good care in Canada, but, you've got to watch yourself. You got to watch what you're taking. You got to watch your, your medications, your diet. I came out and I was told, watch my sodium. My sodium levels were low. That's what crashed me almost in February. I was there for 5 weeks. So, there's a couple of things that had happened where they were going to give me heparin. My platelet levels were so low that if they would have given me that, I would have died of internal bleeding. You need to be the squeaky wheel. You need to ask questions. You need to call social work. Even now, after my transplant, I find it tough to navigate through and get answers I want. But I'm a bit assertive sometimes, and you have to be that way. And it takes a lot of people to go through this and to have a support system. You've got to, I thank God every day for my girlfriend and my sister, because if it wasn't for them, I wouldn't be here today. It's literally my sister too right now. But you have to ask questions, ask for counseling. Counseling has gotten me through this. I never thought that I would be where I'm at now, and I struggle with it even today. Again, ask for the social worker, ask the doctor to speak in English terms. It's very tough to understand as they go in and out because there's so many patients. The doctor on the left is my ICU doctor, which I went into 2 weeks after my transplant. I'm going to see her tomorrow. The far right is 2 months after my transplant. It's my birthday. And then the other two pictures are from Christmas and as of last week. So, that's my story. There's so much to it that I've forgotten, that I can't really remember the early days in 2016. But, again, you have to push. You have to be the squeaky wheel. You have to ask for help. And again, have your support system with you as you go to meetings and to understand what you're going through. That's pretty much all I can say about this part of, part 4 of these meetings. But again, I really thank you for the opportunity to be here tonight. And, my story happened so quickly. It happened within, from September of 20 to, right now, sitting here 10 months after my transplant. I'm very lucky. I was given 6 months to live. And, again, I thank you very much for letting me be here.
Great. Thank you for that, Andrew. Open up here. Perfect. All right. Well, we're going to work our way into our question and answer section for the moment. So with our question answer, it's going to be, we're going to have some questions that we've had ahead of time that we asked some of our attendees who registered, and we also had some questions from the audience going in. So what I'll do is I'll just get the speakers on camera, and we'll have pretty much all of us available. That way we can pretty much answer the questions that we have going on. So I'm just going to open this up. Okay. All right. So just a kind of this is kind of session 1 of the webinar or the series that we're going to be going through when it comes to liver transplant. I guess one of the main questions that we get from the audience, generally speaking, would be again, navigating the system like Andrew was mentioning. So maybe Dr. Tsien, if you can maybe just highlight some quick aspects in terms of what would help people navigate the system when they're in this early stage and they're trying to find ways to seek help, or perhaps are wondering what they can do to kind of help themselves, whether it's social support, whether it's support from the family, anything that maybe you can think of that will probably help individuals who may be in similar cases like Andrew was about a year ago.
Yeah, no, absolutely. I really sympathize with Andrew because liver disease is so complex and manifests in so many ways. And I think that, it's honestly like, write things down. Like and you have to bring someone with you to all your appointments. You have to write everything down. As I mentioned, the Cirrhosis Care website tries to help by providing sheets. When I have patients with ascites, I tell them, you need to write down your daily weights, your blood pressures, you basically need to keep a diary of like everything that's going on. And it's really important that you take this journey with somebody else because it is extremely confusing. Lots and lots of advice. Like every single time I would see a patient, you look at how many things you have to deal with, right? You have to talk about the underlying disease, treatment of the underlying disease, go through all the complications, treatment of each complication, like transplant, like it's a very complex thing. And so I would say that, writing everything down, having someone with you and just asking like the questions, like when, do I need a liver transplant right now? And we are happy to take referrals from the community physicians, and they will call us sometimes if they're not sure when to refer someone or not. And so we do this all the time. We have patients, we have physicians calling us from all over. We also deal with Winnipeg, we have meetings with physicians talking about, all the subtleties of when to list someone, when to send someone to a bowel. So, there's a transplant hepatologist on call 24/7. So if a doctor's ever unsure when to refer, like we are available all the time. It's a really difficult journey that I'm not sure gets that much easier post-transplant in terms of like complexity of care. So that's why we really do insist on, to have someone on that journey with that person to really support the person.
No, that's very helpful. One question came through our feed right now in terms of diet. Now, Andrew covered some quick aspects on diet. Anything in terms of diet and helping control some of the hepatic encephalopathy complications? So maybe Andrew can touch on it afterwards in terms of what maybe he's done. But Cynthia, anything on your end in terms of those who are struggling with hepatic encephalopathy, what they can do from a dietary perspective?
So actually, there are studies that have shown that so basically what happens is when you break down protein, that's where a lot of the toxins that deal with encephalopathy come from. So it used to be that people were on protein restricted diets. We actually don't do that anymore. There's actually been studies showing that limiting your protein actually doesn't, improve encephalopathy. There's always been like, one or two patients who said, oh, like after, like I ate a Thanksgiving dinner and then I became encephalopathic. So maybe like a enormous bolus of like, meat protein, if someone clearly didn't have other reasons to become encephalopathic, I might have believed it once or twice, but often, we treat it with lactulose, the encephalopathy, which tastes terrible, causes bloating. So 9 times out of 10, it's more like the person didn't take their lactulose rather than like, oh, I ate a lot of protein and then I became encephalopathic. I mean, I won't say it's never happened, but it's pretty rare. And so the main issue with cirrhosis is, as you can see, like all the metabolism is sort of deranged and it's really easy to lose weight. And as you lose weight and you get weaker, it becomes more concerning whether you're a transplant candidate. So what I would say is, in general, I actually tell people to eat more protein, multiple small meals throughout the day, because at the end of the day, it's more important that they gain weight and muscle and preserve what muscle they have, rather than try to limit their protein because of concerns around encephalopathy. But there are other dietary restrictions based on like ascites. So like, again, very complex. The Cirrhosis Care website I find is really good. There's like a nutrition My colleague in Alberta developed a whole nutrition guidebook on like how to eat when you're a cirrhotic patient. And it's a good thing to see a dietitian and try to increase your protein and basically reduce your salt.
That's great. Andrew, anything to add on your end from your experience with hepatic encephalopathy in terms of maybe some coping mechanisms, what you may have done or somebody indicated from your healthcare team that have helped with some of the episodes, or any of the other complications that maybe some of the audience members may be looking for some general answers, because oftentimes they look for some answers to what may be helpful for others could be helpful for them. So anything that comes to mind.
Yeah, what I was told, and again, lactulose became a food group in our house. It came to where I was told that as long as you go to the bathroom 5 times a day, I know it's kind of gross, but you have to stay regular. You have to, I watch my sodium, I watch my fluids. But again, lactulose was such a staple because that caused so many issues. And when I went into ICU, that's what they used. They pumped it in both ends of me, and that is the only way that I'm here right now. And I mean because again, my bowel stopped working. Because once one thing stops working, then my spleen was enlarged, and my bowel was dilated so bad. So keep regular. That's really pretty much all I can say. I mean, it pretty much saved me, and I kept on it for 3 shots a day, and that's pretty much it. I mean, just watch yourself. I mean, I counted how much fluid I took in, sodium, none of it. There was no salt. Still don't use salt. So that is pretty much, it's tough. You learn every day, and hepatic encephalopathy is not nice. I was down 3 days every time. Didn't know who my girlfriend was. Didn't know who my friends or my kids were. Thought I was peeing in the bathroom. It was the closet. So, it's just stay regular. I think, doctor, Cynthia, maybe that's pretty much the only thing I can say.
Yeah, absolutely. Yeah, the lactulose gets rid of some of those toxins that are floating around. So it's really important to take the lactulose, and everybody is different. Like some people need to take the lactulose twice a day. Some people need 5 times a day. And it's like not a great, it's really not a great medication in terms of like patient satisfaction. So that's like, one of the indications for transplant, right? Because we don't want to maintain you, like having you have to take lactulose for the rest of your life is not any sort of good quality of life.
Yeah, because you do get a dependency on lactulose and abdomen, some of that stuff, because it swells your stomach up, and you become dependent on it, and it's not good. So there's a lot of things that I do now that again, stay regular. That's one of the biggest things that sticks in my mind, because that was my biggest problem, and that's why I was on life support, was because of that.
Yeah, it really shows how it's you really have to kind of take care of yourself and be part of this team along with your healthcare team. They can only work well when you're doing what you need to do on your end, and vice versa. I think that's kind of where this collaborative team effort really works. And we definitely hear stories, and I'm sure both of you have some experiences where one party may not be as clear and other party may not be doing what they're supposed to, whether it's adherence to medication or whatever else it may be, and it really affects quality of life and sometimes long-term outcomes. And so it's important to be very, very clear and have that talk with the healthcare providers and be aware of what's going on, but of course, do what you can on your end as well. We'll take one more question here. It's specific to the 6-month rule. Dr. Tsien, I guess the question is, when did this 6-month rule, when was it implemented, and does it apply to Ontario specific? Is it the same in some of the prairie provinces or out in the Atlantic provinces? And I guess what's the general national approach to it, if anything?
Yeah, that's a really, really good question. So healthcare is provincial. So there is like no national rules. Every province has its own rules. In Ontario, this was initially instituted a few years ago as a trial. The trial is now over, and pretty much, we haven't heard anything differently from TGLN, which is basically like the provincial institute that oversees organ donation. And so we're continuing with the criteria that we implemented previously. I've asked this question to my colleagues across Canada. Pretty much everywhere now does not really adhere to a 6-month rule, except for Halifax, like the Atlantic provinces. And I think it's because they've been having issues with enough personnel. So like really this whole idea of assessing someone from an alcohol perspective really rests on psychiatry availability, right? Because like, as I said, like alcohol use disorder is actually like the DSM-V criteria. So basically the DSM is like the book for psychiatrists to diagnose all sorts of disorders, right? Like depression and other things. And so, you know, it was felt that transplant hepatologists, you know what I mean? Like we are very good with cirrhosis, but in terms of alcohol, you know, we're not making those judgments if someone has an alcohol use disorder, you know, needs treatment, that kind of thing. So usually, like most places, will be a collaboration between hepatology and psychiatry. So I think in the Atlantic provinces, unfortunately, because of ongoing, you know, resource issues, they don't really have a psychiatrist to implement this. But everywhere else, generally, there is no 6 month. It's more, you know, do you have a risk for drinking alcohol again post-transplant? And obviously alcohol consumption is a very complex condition. And there's multiple factors to sort of predict, you know, whether people are going to drink or not again. And again, it's really important to emphasize that you know, there's a lot of stigma around alcohol consumption, but, you know, in some people it's a disease, right? Like it's a real like addiction disease. And so it's really about making sure that disease is well controlled prior to transplant and after transplant. And so pretty much I would say everywhere in Canada now, like the transplant programs are making a sort of a case by case decision rather than a blanket. You know, it really wasn't fair, right? Like if you were 5 months and, you know, 29 days versus if you're like 6 months and 1 day, right? So it's no longer like a really clear like cutoff time. And people were using 6 months, you know, to see like, would the liver recover, you know, now that you stop drinking, also a sort of like as an indication, right? Like if you could last 6 months without drinking, right, then the hypothesis was that you would continue to stop drinking, right? But you know, these are sort of old criteria, and now there's more data coming out indicating that, you know, we're probably better at indicating like who's going to survive and not survive with alcohol abstinence, you know, who's going to continue drinking or not. So I think that's sort of more old school thinking, and now definitely we've turned a new page in terms of like transplantation for alcohol consumption.
No, great. Thank you for that. Really, yeah, absolutely. I think that's a great way to conclude that question. It's one of the more common questions, whether it's something that's alcohol related or folks waiting to be placed in the transplant list, which is kind of what our next few sessions that are part of this webinar will address, that journey kind of leading up to the transplant process, eligibility, accessibility, assessments, and then kind of transitioning towards the living donation aspect and some of the post-transplant journey. So, yeah, I definitely want to thank both Cynthia Tsien and Andrew for those great presentations. Of course, our partners at the UHN Ajmera Transplant Centre and the Centre for Living Organ Donation as well for helping us with this webinar. So, as you can see here on the slide, those the 4 sessions that are upcoming with this transplantation series. So we're going to be looking at, speaking, of course, the session 2 will cover the living liver donation and transplantation. And Andrew mentioned it briefly, but his sister was his donor as well. So that was a very, it's a very touching and remarkable story. And when we go through that educational series, you'll get a better idea as to how that process works. And there are session 3 and 4 will discuss the pre-transplant journey. So that's where we cover the assessment aspect of it and some of the eligibility criteria. And then, of course, the post-transplant journey. So, of course, Andrew's story is far from finished from what he spoke in the 20 minutes today. But both myself at the Canadian Liver Foundation and, of course, our partners at UHN are going to try to get a full story from him, and he'll be able to share a story in a better fashion, in a written fashion, a blog post in the next probably few months, so that people can see and understand the full spectrum of what he's been through and how you may be able to get some insights and possibly some assistance from what he's been through to get a better idea as to your journey. So again, if you want to register for these webinars, there's the link in the bottom, Eventbrite link at the bottom. That way you'll be notified for upcoming events. And of course, stay connected with both ourselves, the CLF and UHN on social media for more information on upcoming sessions. And this webinar will be available on both the CLF and the UHN website, Facebook page and YouTube channel, probably in the next few weeks. So if you weren't able to attend this webinar live, it will be available on our social media channels afterwards. Of course, to learn more about liver disease or to find out about the CLF as a whole, liver.ca is our website. And be sure to follow us on social media for the most up-to-date information on liver disease and health tips. And of course, for information on transplant and living organ donation, do visit the UHN website, which is uhtransplant.ca. So I do want to thank you all for attending. Until next time, and take care.